রিজভি,
হ্যাঁ
স্যার
এই স্যারের খবর কি? শামসুদ্দিন স্যারের খবর কি?
স্যারকে দেখে আসলাম এই সন্ধ্যাবেলাতে। স্যার এখন এমনি ভালো আছে। স্যারের তো এমনি একটা সিমটম ছিল দুর্বলতা,
হ্যাঁ,
ভাত খেতে পারতো না।
মনিরুল হাসান ভাই বলছে ওদের স্যারের খাওয়া দাওয়া করতে পারতেছিল না,
হ্যাঁ
স্মেল লস।
শ্বাসকষ্ট নাই বুঝছো। তারপরেও তোমার তোমার আব্দুল্লাহ দেখে, আব্দুল্লাহ তো সব ওষুধ দিয়ে দিছে স্টেরয়েড সহ বুঝছো।
হ্যাঁ,
আচ্ছা, তো দেখা যাক, আল্লাহ আল্লাহ করতে হবে। এই রোগগুলো তো, এই রোগ তো তোমার কিছু বোঝা যায় না বুঝছো। ভেরি পিকুলিয়ার অসুখ এটা, কারো কোনো কিছুই হয় না বুঝছো, কারো চট করে কুপেকাত হয়ে যায়, ধরে
হঠাৎ করে ফেলে দেয়।
হ্যাঁ, এটা বোঝা মুশকিল,
বোঝা মুশকিল, রাইট,
জানে।
এক্স্যাক্টলি।
মোশাররফ,
আসসালামু আলাইকুম।
আসসালাম। 9টা বেজে গেছে, তুমি শুরু করে দাও।
স্যার
আলোচনা শুরু করে দাও।
Your internet is unstable. কিভাবে করে
স্যার স্যার আমজাদ স্যার শুরু করতে পারি না?
হ্যাঁ, শুরু করে দাও।
আব্বা সাউন্ড কমায় রাখো।
Welcome to all. Today's webinar organized by ABC of Joint Replacement.
মোশাররফ ভাই, নেটে কোনো সমস্যা?
মোশাররফ স্ক্রিন শেয়ার।
Yes. শোনা যাচ্ছে? Welcome to all.
Yes, yes.
হ্যাঁ শোনা যাচ্ছে, বলো।
Today's webinar organized by ABC of Joint Replacement. The ABC of Joint Replacement previously couple of months we have arranged same sorts of webinar, and we have completed hip total hip replacement. From today we start knee replacement in a details. Today our topic is the selection of patient and pre-operative planning for total knee replacement. It's vital for any good outcome surgical procedure, selection of patient and pre-operative planning. So today's panel of experts, there are a good number of experts from Bangladesh. First of all, our honorable teacher, Professor Dr. Abdullah Rijvi, ex-president Bangladesh Orthopedic Society, ex-director NITOR, president Bangladesh Spine Society. Welcome, sir, and good evening. We have another panel of experts, Dr. S.M. Amir Hussain, is associate professor and head of orthopedic surgery, working in Shahid Sarwardi Medical College and Hospital. Welcome, Amir sir. And we have another legend, Dr. Parvez Hassan, professor of orthopedic surgery, Ibn Sina Medical College Hospital. Welcome, Parvez Hassan. Today's speaker, renowned orthopedics, arthroscopic and arthroplastic surgeon of Bangladesh, Dr. Wakil Ahmad, associate professor of orthopedic surgery, Shahid Tajuddin Ahmed Medical College Hospital. And I am Dr. Syed Musharraf Hussain, professor of orthopedic surgery, Jalalabad Raghib Rabia Medical College. I am with you as a moderator. So, you know, today's topics is selection of patient and pre-operative planning for total knee replacement. Now I am requesting Dr. Wakil Ahmad, please present your paper. Dr. Wakil Ahmad.
Yes. Is it visible? Is it visible?
Yes.
Thank you, Professor Syed Mosharraf Hussain, respected panelist of today's webinar, our respected teacher, Professor Khandakal Abdul Rizvi sir, Professor Amjad Hussain sir, Dr. S.M. Amir Hussain sir, and Professor Parvez Hassan. Other delegates, my senior and junior colleagues, welcome to my presentation. My topic is today for selection of patients and pre-operative planning for TKA. This is Dr. Wakil Ahmed. I'll be with you with my presentation today. So, the planning, pre-operative planning is nothing but a checklist for the pilot before flying to the sky for a smooth journey. In the same way, the careful pre-operative plan is of critical importance, and sometimes it determines, most of the time it determines the success or failure of the procedure. Today, we will talk on the pre-operative clinical evaluation of the patients, indications and contraindications of the TKA, medical condition of the patients, radiological assessment and evaluation, preparation of the surgeons and templating. The medical evaluation and the radiological evaluations are the cornerstone of pre-operative evaluation before any surgery, especially the joint replacement. So some pre-operative workup, the comprehensive history of the patient is one of the important part. Pre-operative medical assessment of the patients, the clinical examination of that patients, radiological assessment and evaluation, implant selection and counseling and counseling of the patient. Fitness of the patient for surgery, and at the same time, the fitness of surgeon and his team. We should give special precaution for the patient who are in high risk of thromboembolic manifestation. We should give special care to the patient with urinary tract infection or obstructive uropathy. And of course, we should be careful in this special situation now, the COVID-19, for doing any joint replacement. Regarding the antiplatelet or aspirin, there are two thoughts of school. Some of the surgeons want to stop is 5 to 7 days before surgery. And another thought, they want to continue as a prophylaxis. Urological or dental procedure before surgery if any needed. Any medical condition that should be brought under control, and any skin lesion, eczema, or pyogenic infection should be treated before surgery. If the patient had any comorbid conditions, any immune deficiency stage, it should be evaluated. General health condition of the patient's strength of the muscle, any neurological deficit or disease, involvement of the other joints of the body, previous ambulatory status of the patient, and finally the body mass index of the patient. All these things should be evaluated before planning for a total knee arthroplasty. And regarding the limb that is in which we are going to do the surgery, that joint, what is the deformities? Is there any shortening of that limb? What is the range of motion of the joint? What is the status of the collateral ligaments? Is there any previous surgery or scar? Neurological status of that limb and other joints and knee screw you should assess. The total knee arthroplasty is a gold standard procedure, gold standard option of the treatment of end-stage arthritis, which gives and relieves the pain effectively, which corrects the deformity, and which keeps the stability and provides good motion of the joint. So, and all these things are the demand of the patient, at the same time, the desire of the surgeon also. The counseling and consenting is important part of pre-operative planning. What is the aim of our surgery? what we are going to do, what will be the benefits after surgery, what may be the possible risk and complications after surgery, what will be the modification of the lifestyle of the patient, and the possibilities of the revision of the surgery. All these things should be clearly defined in details to the patient and his attendant relatives. So the aim of our pre-operative clinical evaluation is the selection of an appropriate candidate for total knee arthroplasty. The primary indication for the total knee arthroplasty is the pain and the loss of motion, but we must always exclude the claudication pain and radiating pain from other site, from spine or from other joints. So in advanced arthritis, in persistent pain, which is not responding to the other medical treatment or other options of treatment, when there is progressive deformity and instability, we recommend for total knee arthroplasty. But if you do total knee arthroplasty in a patient with minimum complaint, with less complaint, the patient will be less satisfied of a surgery. So we also should keep in mind this thing. These are the indications of surgery, you know, the advanced osteoarthritis, advanced rheumatoid arthritis, osteonecrosis, post-traumatic arthritis, inflammatory arthritis, and some other conditions. In this case, we do total knee arthroplasty. In X-ray, you see there is the narrowing of the joint space, reduced joint space in the middle compartment of the joint. You see in the rheumatoid arthritis, there is no joint space almost. And before planning, we should remember some absolute contraindications where we should never do the total knee arthroplasty: the knee sepsis, chronic infection, dysfunction of the extensor apparatus of the knee joint, severe vascular disease, recurvatum deformity secondary to the muscle weakness, and a well-functioning knee arthrodesis. These are the conditions in which we should not do absolutely the total knee arthroplasty. There are some relative and controversial contraindications also. You see the medical condition in which the patient cannot tolerate the anesthesia. Inadequate soft tissue coverage over the limb or over the joint, the morbid obesity of the patient, neuropathic arthropathy, and previous history of osteomyelitis around knee joint. These are the relative contraindication and controversial contraindication. So all these things we should keep in mind before planning. So a comprehensive history, detailed examination, patient's medical comorbid conditions, drug history, and laboratory test. These are the vital parts of planning. The diagnosis of the disease alone is not enough to guide the surgeon to the correct choice of the procedure. A good radiological assessment is also vital part of the planning, you see. And for that, we need a complete lower limb standing view, AP view X-ray to see the load-bearing axis of the joint, to see the anatomical axis of the joint, and to see the mechanical axis of the joint. From this, we can see if there is any deformity in the limb, if there is any valgus or varus deformity, if there is any shortening of the limb, we can assess from these X-ray before planning surgery. So the varus, valgus, or multiple complex deformity we can assess. From lateral view of the X-ray, the Insall Salvati ratio. This is the ratio between the patellar ligament and patellar length. From this ratio, we can assess the level of the patella, whether it is patella alta or patella baja. So position of the patella is also important, and we should assess before doing, or any other pathology in the patellar ligament also can be assessed from this ratio. The Marsan view, from the sulcus angle, we can assess the patellofemoral articulations. Is there any defect or any deviation of the patella from this? Sulcus angle and congruent angle. Congruent angle is usually within 16. If it is more than 16 on any side, there is deviation of the patella. So it is also important for patellar tracking after surgery. We should keep in mind. From the sunrise view, from the tunnel view, we can get some other information, whether how many loose bodies are there, what is the condition of the articular cartilage, is there any osteochondral defect or lesion. And from the kneeling view, we can assess the transepicondylar axis and versus line, there is epiaxis, the entry point into the femur, and rotation of the femur. During surgery, we usually give the 3-degree external rotation, and how much the rotation should be, we can assess preoperatively from this X-ray. So from X-ray, we can determine the femoral or tibial cut. We can identify the bone defects, subluxation of the joints. We can anticipate the soft tissue release and contemplate the prosthetic components. In this X-ray, you see there is tilting of the patella in one side. And if we see this X-ray before doing a total knee arthroplasty, it allows the surgeon to do a lateral release after knee replacement is completed. So all these X-ray can give some important clues and important guide to the surgeon for planning the total knee arthroplasty. You see, in arthritis, how much we should cut from the distal femur, how much we should cut from the proximal tibia. We know the cut of the tibia and distal femur always should be perpendicular to the axis of the tibia and axis of the femur. So that's why anatomical axis and mechanical axis is essential. Is there any bone defect we can assess from the X-ray, and whether we need any augmentation or bone graft, we can assess preoperatively. If there is any extra articular deformity, that is in the distal femur or proximal tibia, or sometime in the shaft, if there's a deformity and how much should be corrected, we can also assess from this X-ray. Another important part of the planning is the templating. We can do it by conventional method and by digital method. By templating, we can assess the size of implant. You see, from the lateral view, we can assess the femoral component, and we can do it both digitally and manually. Preparation of the surgeon is very vital. Proper and preoperative planning may simplify the whole surgery. The time which is lost in preoperative planning is always regained during surgery. But what will be the intraoperative setting, the theater setup, the type of the anesthesia, position of the patient, whether we need any tourniquet, what extra equipment we need, what will be the implants, what will be the approach, draping method and closure, all these things we should keep in mind, including the arthroplastic table, that is TKR table. You see, the foot rest is a vital part during giving incision or any total procedure. This part is very vital, and this table should be available, always available for total knee arthroplasty in the operation theater. There's some extra consideration we should keep in mind, whether we need any blood during surgery, whether we need any bone graft, any backup, especially the power system, or we need any co-surgeon or good assistant and ORP. All these things should be considered before planning. And finally, the day before surgery, we should advise to the patient to continue the regular medications if the patient already taking early light dinner on the night before surgery, 6 hours of fasting before surgery, and informed written consent and site marking of the limb. These are the part we should do the day before surgery. The surgeon who are failing to make a good plan is inviting a failure definitely. There is no condition that cannot be made worse by the surgery. So do the surgery before doing it by a good planning. And three-dimensional thinking of the surgeon, the prediction of the surgery preoperatively, which improves the precision of the process, which shortens the length of the operation and reduces the complication. Thank you very much. Thank you for being with me and patient hearing.
Thank you. Thank you, Dr. Wakil Ahmad, for your nice presentation. I have seen good number of participants. They are listening our presentation. So I am requesting all the participants, please put your question if you have any query regarding the pre-operative planning and patient selection. Our panel of experts are, they will give your answers. So now I'm requesting Professor Abdullah Rijvi sir, please comment about this presentation. Sir, please unmute. Please unmute, sir.
Thank you, Mr. Rao. Wakil, thank you very much for your beautiful and very elaborate presentation. Not only the presentation, I also liked the slides you made. I did not know you spent a lot of time probably in making all the slides very interesting and very clear. So it is now very evident from your presentation that the importance, you have mentioned all the reasons why pre-operative planning is so important. In one slide, you have also mentioned that you might lose some time in planning the pre-operative planning and templating everything. But ultimately, you mentioned that ultimately you will regain the time you have lost during your preparation. This is a very excellent comment. It is very true. Sometimes we fail to do complete templating during in our surgeries, and ultimately during surgery we sometimes we come across with different kind of difficulties. So this is one point. Other point is that this is for our young surgeons. Totally replacement is very common procedures now in European countries and this in Africa, in other developed countries. In our country, the number of cases are increasing day by day. The reason for that is this is both in terms of function and longevity. This total knee replacement has come out to be a very successful procedure. And unfortunately, in our country, there are a lot of patients because of many reasons. One reason is economic reasons. Other reasons, they often fail to put their trust on us. So that is the reason. So number of cases are not that great in our country. In doing totally replacement, Wakil has mentioned in another slide, which I liked. Actually, there was a study. The study showed that the patient who had a lot of symptoms before surgery, they were very grateful after surgery. But the patient who didn't have much symptoms,
less complaint.
Yes, in spite of the changes in the X-ray. In me, the peculiar thing is that sometimes you will find a lot of changes are seen in X-ray, but patient do not have that much symptoms. And patient has much symptom without much changes in X-ray. This is a paradox. Sometimes you see in knee. So always don't forget that this is the operation patient should earn. Don't influence patient to go for this surgery. If you do that, then you may be in a trouble. rather than if patient is asking for the procedure, then do it, and patient will be very grateful to you. And regarding this templating and other things, this is a practice. You'll have to do it every day. Unless you do it regularly, then many of the steps you forget or you miss. So I would request my young surgeons to practice almost in every cases, to do a proper planning, do a good templating. Regarding the obesity, you have also mentioned the morbid obese persons. Be careful about doing surgeries in morbid obese person. This is the group who has body weight more than 100 pounds or like that, or 100 kg, maybe 100 pounds.
40% above, 40% above the.
It's more than 40.
40, yes, sir.
The best calculation is when the BMI is more than 40, we
Yes.
consider them as an obese person. Before doing this surgery in this obese person, we can ask them to reduce weight. Okay. Take some time, ask them to reduce weight by controlling the diet and doing exercises. But the problem is when the patient has some knee problem, okay, when they cannot work very well and they are very reluctant to go for these exercises, then it is really, really very difficult to control the control and to reduce the weight. Okay, and what other things I do not just remember all the important issues to be discussed now. Okay, if there is any other question, then I will participate.
Okay, sir. Okay.
Thank you again. Thank you, Wakil, again for your beautiful presentation.
Thank you, sir.
Thank you, sir, for your nice comment. So now I am
question.
Yes, sir. Now,
if there is no question, I can ask Wakil to tell us about this importance of maintaining the joint line. Okay.
Yes, sir.
In doing total knee replacement, we do some few things. One of them is bringing the alignment in the right position. Okay. Other thing is that soft tissue balancing. Other
soft tissue balancing is vital, and alignment also vital.
Maintain the joint line. So can you tell us about this importance of this maintaining the joint line?
If we maintain the axis, load-bearing axis, so that is very important. Otherwise, if we cannot correct it and cannot maintain it, the failure will be more and more. And this is one important thing regarding, and balancing also important. If there is both collateral, there is medial and lateral collateral, these are not well balanced and well strength, failure rate also more. And in case of some laxity in the collateral ligament, we can pre-operatively select the CCK implant.
So
condylar constraint.
Speaker, Dr. Wakil.
Yes.
Can I ask one question?
Yeah.
Can you explain elaborately about the anatomical axis and mechanical axis?
Yes.
How you measure pre-operatively and how you re-established para-operatively?
I want to show the picture at the same time, so it will be very clear to you.
So that it will be easy for our participants.
I have the picture here. Yes, you see the anatomical axis and you see the mechanical axis. From the center of the femoral head, you see, to the center of the knee joint or center of the patella. You see the line, red line? This is the mechanical axis. This is the mechanical axis that is weight bearing. And the anatomical axis is the two in shape. In 2 point, the midpoint, there is a transverse line, you see here. Transverse line you see here, and transverse you see here. The midpoint too, if you draw a line along the long course, there is a anatomical axis. So normally the angle is usually 6 degrees, 5 to 7 degrees, the angle between the anatomical axis and the femoral axis. So, and that is the valgus, usually normal is a valgus, that is 5 to 7 degrees. in case of female, it is a little bit more, and in case of male, it's a little bit less. So these valgus we should assess before surgery, because in case of female, we should keep a little more valgus during surgery. In case of male, we keep a little bit less. And if this valgus angle is not maintained before surgery, what correction we need during surgery, we can plan from this axis. And that's why this is very important. And another one is if there is any extra articular deformity that is in shaft or distal femur, we can also assess from the axis, and that we can correct. We can plan to correct during surgery. That's why these axes are very important.
Wakil,
Yes, sir.
I would like
Yes,
to
Yes, sir.
add for this
That's
clarification.
Yes.
The angle, which is very important, because when we cut the distal femur,
Yes, sir.
okay,
Yes,
we pass a rod intermedullary.
Intermedullary rod. This is
along the anatomical
axis. Yes.
But in reality, we want a perpendicular cut to the mechanical axis. Do you understand?
Yes, sir.
We do not cut perpendicular to anatomical axis.
And that's why
want a cut perpendicular to the mechanical axis.
Mechanical axis. And that's why when
the cutting jig.
Yes. After introducing the intermediate rod, we set the jig
Yes.
in 7° or 5° valgus.
Yes. So that you can get a true perpendicular line to the mechanical axis. This is very important.
Okay. Thank you. Amit sir, can you add something?
Okay, thank you, Dr. Akhil, for a beautiful presentation. I think you elaborately present the pre-operative planning and so on. Regarding anatomical and mechanical axis, this is the vital for the longevity of the implant and also success of surgery. I think this must realize during operation by the long rod which passes through the medullary cavity, and also there is a another device from the hip joint to knee joint to see the there is some implant and also some device that plan the axis during operation. And also for the tibia, we use the axis from the tibial spine to second to toe, second to
ankle,
axis. And already Wakil discussed the everything. I think this is the good presentation. Thank you, Dr.
Thank you, sir. So, Dr. Parvez Hassan.
Yes, thank you very much.
Wakil has shown one slide. There is a table. What is the importance of this table? Total knee table. Is it always needed for replacement of knee surgery? Can you understand? Parvez Hassan, sir? Can you hear? Parvez Hassan, sir?
So, what is the question, please?
Question is the table. You have shown a table.
Foot rest is vital. Foot rest. During operation, I think there is a 90° and also on 20°. Foot rest. This is for the cutting of the tibia and also cutting of the femoral.
Yes. The table is important.
Table is also important
because
okay.
See the table. You see the foot rest here.
Foot rest is vital.
This one, huh?
Yes,
In,
yes,
in
is
our
a-
country,
yes.
in our country, in many
Yes, sir.
put
Just unmute, sir. Please unmute.
Sir, please
You are
unmute.
muted.
Sir, no. Sir is unmute, but sir, your device probably a problem.
Oh, maybe. Anyway,
Okay,
Yes.
sir.
go
Now-
ahead.
Okay, sir. Okay.
Now,
Can you hear?
Rizvi sir, please continue.
Can you hear me?
Yes, sir.
Yes, sir.
Yes, it is audible.
If you do not have that kind of table, because that may not be available in many of these hospitals in our country, then use a sandbag. Okay,
Yeah.
sandbag and place it in such a position that an A is maximally flexed. You need a position where the knee is maximally flexed, okay, to work on the tibial side, especially on the tibial side. So this is very important. Okay.
But sir, this table is advantage of this table is the footrest you can adjust when you need 90 degree.
This is
You can
very
adjust.
in some of this modern tables, if it is an orthopedic table, then
Yes.
you will get this kind of footrest or whatever may be. But in many of these clinics, actually, they actually buy a general table rather than an orthopedic table. Okay.
Yes.
So if you can buy a good orthopedic table, there are few orthopedic table available already in our country, especially in Netors where they have bought some good tables. They have in the Labate Hospital in Amjad Center, there is a good diamond band orthopedic table. At Green Life Hospital, we have procured one for and in some of this, I think in Apollo and United, they have that kind of good orthopedic tables. So when you are setting up a center, try to buy a true orthopedic table for your convenience. Otherwise, surgeries may always may be difficult. So life should be easier now in modern days. Okay, thank you.
Thank you, sir.
Thank you, sir. So another question, during proper preoperative planning, you need to know the anatomical axis, mechanical axis by a special X-ray that is known as scanogram.
Scanogram.
So I am
That is,
requesting
that is long.
Parvez Aslan sir, can you explain what is scanogram, how it works, and is it possible in Bangladesh? Anywhere?
Yes, it is done in only popular diagnostic center. It includes the hip, femur, knee, and up to the ankle joint to find out the mechanical axis and anatomical axis. And if you want to draw preoperatively, you need a scanogram. And scanogram is a must for finding the exact value of the mechanical axis and anatomical axis, varus angle, valgus angle of the knee is very essential. And it is found only possible
orthoronjogram. 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 Ronjogram, no? Ronjogram. It's okay.
This
Okay.
is standing APB only.
If you do not have that facilities, what you can do, you can take X-rays of parts different in one or two X-rays, then you can join together.
Join,
Okay.
Some center do this.
Yes, because in all the centers in our country, they don't have that facility. Okay. So this is another issue. Another important issue is the X-ray magnification. When you will be templating, you must know the magnification of the X-ray.
Yes,
For
yes.
that reason, you can ask the radiologist to give a standard magnification.
That is 100%.
Yes, that is 100%. Okay. So this is especially important for the hip actually, but this is also important for the knees as well.
Yes, sir.
Thank you, sir. So another question is, sometimes patient may ask after replacement whether he or she would go back to normal life, or what would be the lifestyle, what would be the protocol of rehabilitation. Can you say something about this? The speaker, Wakil Ahmed.
Yeah. And that is the important in one of slide I already mentioned. We should see the patient before surgery. What is the pre-operative status of the patient? In pre-operative status, whether the patient can walk, what is the muscle strength of the patient? Is there any neurological deficit? All these things we should assess, because in a patient, if you do surgery, the patient has some neurological deficit. In a patient, the muscle is weak, or the patient could not walk before surgery. In that case, the outcome will be poor. So planning is important. That's why in which case we will do and in which case we will not do. So after good planning, we can accordingly explain the patient.
What would be the post-op rehabilitation of a total knee replacement patient?
So what we do in our practice usually after removal of the drain and other tubes, that is if there is any catheter, usually on the third day we do an X-ray. We do an X-ray and see the condition, bone and other condition, and we advise the patient to walk, especially with aids, the walking aid, usually and quadriceps muscle, a gradual knee bending exercise. And we were working with aid is full weight bearing. And we usually remove the stitch after 2 weeks, and all muscle, that is quadriceps, hamstring, all muscle strengthening exercise, and gradually knee bending. We usually within 6 weeks, the maximum range of motion. Sometime if the range of motion is more than 110, we 120, we are happy because we don't allow the patient to squat. So if anything, Professor Amdas sir, is available here?
Anything add, anybody, sir?
I can add some. In our country, when
Yes.
you discharge your patient, a patient should at least regain 0 to 90 degree of flexion.
Yes.
Okay, it is better you can achieve that much of flexion before you discharge this patient. Otherwise, patient may not be that particular about doing exercises, and you may get less than expected range of motion afterwards. So this is very important to gain some range of motion before you discharge your patient to go home.
Up to
In
90.
the Western world, so when they discharge early, for them it is not a problem, because they have a kind of setup when the patients can get regular follow-up and exercises. Okay, so in our country, since these rehab specialties
yes.
and rehab centers are not that developed, sometimes as an orthopedic surgeon, you may have to take some of the responsibility of the rehab specialties.
And so one thing I want to add, sir, here, there is in any patient with the poor muscle strength or some other poor status before surgery, we should do some prehab also. Prehab, that is before surgery, we should do some physio and muscle strength exercise. And we, if we do the surgery, then outcomes will be better. That is prehab.
Yes.
Okay, thank you, sir. Okay, is there any advantage of early totally replacement or any disadvantage in late age total knee replacement? Yes, because in our country, most of the patients willingly don't go for surgery early. They wait and wait.
Who will answer the question?
So what is the question?
Yes. Question is there any benefit to do early totally replacement?
For
early stage of osteoarthritis. Early stage or early age?
Early age.
or
For
early
osteoarthritis.
osteoarthritis,
Osteoarthritis of the hip joint,
knee joint.
knee joint.
Knee joint.
Oh, okay. You wanted to say that in osteoarthritis in patients in younger age.
Younger, yes.
Okay, it is a primary
Yes.
osteoarthritis or secondary osteoarthritis.
So,
Normally, osteoarthritis is a disease of these older patients. Younger patient osteoarthritis is developed, and it is always secondary, not primary.
Yes.
Either following trauma or from other diseases like inflammatory diseases. Then it is osteoarthritis. So indication is very important.
yes.
Okay. Unless you have enough good indication, we should not do any kind of arthroplasty surgery, especially in the knee joint. So if there is indication and patient is really earned the surgery, then do it. I will not say early surgery can be beneficial to the patient. Rather, when patient has earned the surgery, do the surgery. Thank you.
I can add some. Yeah, Dr. Musharraf, this is,
Yes, sir.
I can add something as
Yes, sir. Yes, sir. Most
not
welcome.
important. It is the important is the symptom and deformity.
Condition of the disease.
Condition of the disease. If any severe pain and it is not relieved by the medication and day-to-day life is hampering, then you must do the total knee arthroplasty or any arthroplasty. So this is, age is not important. It is the symptom and lifestyle is important. So
Yes, sir.
this is not.
আমি একটু বাংলায় বলি একটা জিনিস স্যার, একটু বাংলায় বলি। জুভেনাইল আর্থ্রাইটিস যেগুলো ইয়াঙ্গার এজ গ্রুপে বেশি এফেক্টেড হয়, সেই সব ক্ষেত্রে পেশেন্ট যখন ডিসেবল হয়ে যাচ্ছে, সেই ক্ষেত্রে আমরা কোনো সময় তার বেশি সময় ওয়েট করতে পারবো না, তাকে আর্লি এজেই করতে হবে। সেই ক্ষেত্রে এজ ইজ নট এ ম্যাটার। কারণ একজন মানুষ যে ভাইটাল টাইম যেটা, ওয়ার্কিং পিরিয়ড যেটা, অ্যাক্টিভ পিরিয়ড যেটা, সেটা ওই সময় যদি সে ডিসেবল থাকে, ওই 60 বছর বয়সে বা 50 বছর বয়সে গিয়ে অপারেশন করার লাভ কি? সেই ক্ষেত্রে when the disability is more, when the status of the patient is disabled, মানে disabling, সেই ক্ষেত্রে early age you can do the surgery and that is a good decision, I think. কারণ অ্যাক্টিভ পিরিয়ডটা তাকে আপনি ভালো রাখতে হবে। আপনি তাকে যদি অ্যাক্টিভ পিরিয়ডে ডিসেবল করে রাখেন, বুড়ো বয়সে গিয়ে আরেকটা অপারেশন করে কোনো লাভ নেই। সেই জন্য কোনো কন্ডিশনে so you can do the surgery in early age.
Yes.
It depends on the condition of the patient, depends on the status of the disease.
সেই ক্ষেত্রে তার কি কোনো লাইফস্টাইল মডিফিকেশন করা লাগবে?
Definitely after joint replacement there are some modification in the lifestyle. You cannot add the patient to squat. You always advise the patient to be alert always, because in any rotational movement, any unusual movement, is and condition of the bone is also sometimes the bone may be osteoporotic, so any vigorous movement is prohibited for the patient. So after any joint replacement, of course there are some modification of the lifestyle. It depends on situation.
Thank you. So Dr. Parvez Hassan, can you add something? Dr. Parvez Hassan, can you hear?
About lifestyle modification.
Yes, lifestyle
or age.
Others.
Actually,
Yes.
No, especially the age of the patient. Definitely, especially age of the patient, some misconception about the age of the patient is here, that the knee replacement cannot be done before 40. This is prevailing. If it is emergency, if the patient is suffering severe pain, like rheumatoid arthritis, who are suffering from severe pain developed, so we should consider his age for replacement. That is early age, we could go for replacement. Especially in other, when their lifestyle is concerned, so we should not permit them for sports activities also. There are a lot of patient wants to run, and especially in case of ankylosing or rheumatoid arthritis, they had very osteoporotic bone, and especially the sometimes refracture comes with periprosthetic fracture. So lifestyle modification should be given preoperatively, that you have to go for a selected and I mean lifestyle should be modified in a very concerned manner. A lot of patient comes after especially they lose their implant, losing implant. Especially they have not given the, I mean, pre-operative advice of that we should advise about the taking appropriate calcium or
I think there is a network problem. Awesome. Okay.
And especially about lifestyle, those village people who usually go for squatting, especially we will request not to go for squat or sitting. Especially a lot of patients I have faced, they after going, they want to pray, they want to go for squat. This advice should be given preoperatively.
Thank you.
I have a question to my teacher, sir, Rizvi sir or Ramdas sir.
Okay. I have
No, sir, the question is this
something
medical
to say,
perspective.
In this issue actually. This is the area, there are a lot of controversies and debates still nowadays going on actually. In Western world, after arthroplasty, some of the patients has gone back to their sporting life. They do play tennis, then and other kind of sporting activities. But in our country, we have limited experience, okay? So we are always very careful about allowing patients to do certain things. Even we do not allow patients to squatting, okay? But in reality, if you follow your patients, you will see many of the patients actually are doing squatting in their daily activities, because without squatting, they don't have other options. They don't have commode at their home, so they have to do the ablution. They have to work in the field, so they have to squat. Okay, and I have many of the patients actually praying in the normal praying position. They are squatting and working in the field, and I have a impression about these activities in a young patient. If the patient is young, if you have done a good job, if you allow patients to do these activities, actually bone remain healthy. Okay, because we know this bone turnover is very important. If the bone health is good, if the bone turnover is good, then this incorporation to the implant is good as well, and that remain good for many years.
Yes.
I have a very very interesting case actually. I did surgery about 14 years back with who had a tumor in the proximal femur actually. Then I did a resection and used a resection stem. Resection stem means it is not a modular prosthesis. It is a fixed prosthesis. There is a ring type of buttress in a stem. It is a long stem, very long stem. I used a cemented prosthesis about 14 years back. That lady is doing everything. After the surgery, he took 3 children, and he is a village worker. He is a poor fellow, poor girl. His husband is not very supportive, because in this whole surgical period, I did not see that lady's husband. Other people came and they helped this lady to get this operation done, and the prosthesis and everything is remaining very healthy and good. So in some of the patients, this may be a very important issue. Activities might keep this joint.
Activity, yes, activity.
Yes, activities
Can
might
I-
keep this
Bone healthy.
fixation good. Okay, but
Yes, sir.
this is we don't have long experience. We don't have any study, so it is better to remain very what do you call it, conservative in allowing the patient to do everything.
There is high flex knee also, sir. There's a high flex knee also available,
Sir.
so we can use that option
Yes,
also.
sir. Parvez,
Sir, I want to say something. Why we give a limited lifestyle? Especially we are afraid of complication. I had a patient of rheumatoid arthritis. I told him, you go do everything. Just after 6 months, he came with periprosthetic fracture. That day, I thought I will never give him the advice of go and run. Second, another patient of hip prosthesis. He was also a case of ankylosing spondylitis. He used to go for regularly in bazaars and other activities. He came of protrusive acetabuly. So complication and overcoming the complication of giving the permission of the sports activities sometimes causes problem. And you know, in this Bangladesh, revision arthroplasty scope is very less. If someone comes to us with periprosthetic fracture or other complication, we sometimes have to advise to go for abroad. That is a very much problem for this our surgical experience.
you are very right in one sense. It depends on what is the original condition of the patient.
Patient.
Okay, you will get patients where bone is not that healthy. As for example, ankylosing spondylitis. In ankylosing spondylitis, you get a lot of bones,
Yes.
but bones are osteoporotic and weak. But in many other conditions where bone is very healthy, then these are the different cases.
Yes.
Overall, considering this good side and bad side, okay. So just carefully and advise patients according to their condition and their case. It is rather individualize the cases rather than generalizing the cases.
So my question is regarding the osteoporosis. If the patient with any condition
Yes.
with bone osteoporosis of the bone,
That is a
if you are planning to do the surgery, so whether you will treat the patient for osteoporosis before, or you will do the surgery then treat the patient for osteoporosis. What is your comment?
I can. It is advised to treat osteoporosis early, especially if times early osteoporosis manage, then go for surgery, then post-operatively again manage the osteoporosis.
Okay, Parvez.
Yes.
Parvez. If it is not a regional osteoporosis, you can get a regional osteoporosis because of this immobility or disease in a particular part. If it is a generalized osteoporosis, treating generalized osteoporosis is very, 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 very difficult. Okay, so of course you will treat osteoporosis, okay, by giving physical therapies, exercises, and medications, everything. But it is very difficult to regain DEXA. If you follow this patients of the osteoporosis, or whatever medications you use, okay, improving the DEXA is very, 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 very difficult. Okay, then so if you have opportunity to treat osteoporosis, of course treat it. But the most of this osteoporosis you will have to do the surgery unless you do the surgeries, especially the patients requiring arthroplasty. For their mobility, they require arthroplasty, whether a hip arthroplasty or a knee arthroplasty to prevent and to improve osteoporosis, you need to do the surgery. So at the same time, do the surgery and treat the osteoporosis. Of course, start the treatment before you start the surgery.
If the disease you are treating by arthroplasty is the cause of osteoporosis, in that case you remove the cause, then treat for osteoporosis. It's good. Yes. Thank you, sir.
Okay. Thank you. We are at the end of the discussion. So I think this was a lively discussion. We learned a lot from our expert panelists, our participants, those who are putting their question and make the discussion successful. Thanks to all the participants, all the panelists. Before the end of discussion, I am Dr. Syed Musharraf Hussain, handed over microphone to Dr. Fazlul Kashem for announcement and conclude the session. Dr. Fazlul Kashem, sir.
Thank you, Professor Musharraf. We are grateful to our great teacher, Professor Khandokar Abdul Awal Rizvi, Dr. Amir Hossain, and Professor Parvez Ahsan for their time to be here as a panel of experts and this lively discussion. Congratulations, Wakil Ahmed, for your nice presentation. Actually, you cover all these things of the pre-operative planning and templating and all these things. We are also thankful to Musharraf Hossain for his nice moderation, and we are also thankful to our participants, especially Professor Amjad Hussain sir was there, Dipankar Nath Talukdar from Sylhet, he was there, and Professor Jahangir Alam of Nitor, I to mention, he was in our webinar. Dr. Mubarak Hussain of Dhaka Medical College, he was here, and many junior. I am very sorry and beg your apology if I fail to mention any senior person. You all know we are becoming busy day by day, and considering this, from this knee replacement, we have bring some changes in our webinar schedule. From now onwards, this webinar will be fortnightly. It was weekly, and we'll arrange it fortnightly in alternate, and it will be on Sunday. And it will be a single talk, and we will complete it by 1 hour. We'll start at 9 and we will finish it by 10. And so our next webinar will be on 1st November, and topic will be how to read pre and post-operative X-rays of total knee replacement. I cordially invite you all to participate to this webinar. Now I will request Professor Amjad Hussain sir to conclude today's webinar.
Yeah, hello.
Yes, sir. Yes,
Thank
sir.
you. Thank you, Wakil Ahmed.
Sir.
And thank you, Professor Rizvi, Amir Hussain, and Parvez and others for their great contribution. Basically, what I thought that it is what you have discussed nicely. I have heard everything. And we have done far beyond our limitation. আমরা শুরু করতে চাইছিলাম যে এটা যেমন ভাবে টপিকটা দেওয়া হয়েছে যে patient selection and templating and the discussion also confined with that. Yeah. But anyway, this is a lively discussion regarding even squatting, not squatting. And Professor Rizvi has nicely said that osteoporosis management, it is not that and what he said perfectly right. I agree with him that you need to do the surgery first and then allow the patient to walk around to do the exercise and for preventing the osteoporosis. So thank you all. What I think we have a good start and for me and Wakil, You
Yes,
did
sir.
a good job. But next speaker, I would also request Fazdu, so that he must be confined with the how the patient, the topics it is given, and accordingly we should be confined. And even then, your what he told today, Dr. Vakil, it should be repeated again, because this is a very complex knee replacement, and the most of the time the patients are not very happy. And Parvez said that the fracture and this and that, periprosthetic fracture. So all these things can happen, and 17 to 20% patients are unsatisfactory after knee replacement. So, but we have to continue it, and we have to do it, and our young surgeons should be encouraged to do it. So thank you very much again for allowing me to talk a little bit. And thank you again. I observed and I heard all the speakers and all the deliberations from the panelists. So thank you. Good night to everyone. Assalamu alaikum.
Thank you, sir.
Good night. Good night.
Good night, sir.
Thank you, everybody.
Thank you very much, sir.
সবাই সবার জন্য দোয়া করি যেন সবাই ভালো থাকে।
Yes, sir.
স্পেশালি আমরা শামসুদ্দিন স্যারের জন্য দোয়া করি, স্যার যেন
Inshallah, inshallah, right.
জি, জি,
এবং
জি,
আমাদের
তাড়াতাড়ি সুস্থ করে দেন, হ্যাঁ।
সিনিয়র সার্জন ডাক্তার সুবীর হোসেন, সেও অসুস্থ, তার কিছু সিমটমও আছে, সবাই দোয়া করি সেও যেন খুব তাড়াতাড়ি সুস্থ হয়। সালাম স্যার, শুভরাত্রি।
Thank you, sir. সবাইকে আসসালামু
সবাই
আলাইকুম।
ভালো থাকো।
Go home, Professor Amjad Hussain, and get rest and have a good night.
Good night. Good night.
Thank you,
স্যার
sir.
যেন ভালো থাকে, হ্যাঁ।
Okay,
Okay,
sir. Thank you, sir.
Thank you, sir.
Thank you.
Thank you, sir. Thank you. সবাইকে, sir.
Thank you,
Yeah,
Musharraf.
looking good, but
Hamza
not
sir.
looking-
Rizvi sir, thank you, sir.
Thank you. Amit,
হ্যাঁ জি স্যার, থ্যাংক ইউ স্যার।
সবাইকে
ভালো
ধন্যবাদ। আচ্ছা, চলে গেছে। মোশাররফ,
Yes, sir.
থ্যাংক ইউ।
Thank you, sir.
মোশাররফের তো ব্যাকগ্রাউন্ড তো খুব সুন্দর।
Sir, এটা
বলছে যে স্পেস থেকে বলতেছে।
স্যার, এটা আপনার কম্পিউটারে
স্যার
আপনার কম্পিউটারে আছে স্যার এটা।
আছে?
জি স্যার,
শিখতে হবে
আছে।
কেমনে করে করতে হয় আর কি। এনিওয়ে,
আমরাও জানি না স্যার, এটা জুনিয়ররা জানে।
লার্নিং নিউ থিংস, বুঝছো?
Sir.
তোমাদের পাল্লায় পড়ে।
আমাদের পরের জেনারেশনে জানে ভালো স্যার।
ভালো থাকো।
জি, স্যার, জি। আসসালামু আলাইকুম।